Okay, hello everybody. Buenos días, o sea, buenas tardes en realidad a todos. Estamos aquí para comenzar la charla Innovating with Data and Social Services. Esta charla la vamos a conducir en inglés. Les damos a todos muchas gracias por venir. Yo soy María Paz Hermosilla, soy directora del GobLab, que es el Laboratorio de Innovación Pública de la Escuela de Gobierno de la Universidad Adolfo Ibáñez. Esta charla es parte de un ciclo de charlas sobre ciencia, datos y políticas públicas que estamos haciendo en conjunto con el Centro de Economía y Política Regional de la Escuela de Negocios de la Universidad Adolfo Ibáñez. Ambos centros somos responsables del diplomado en Big Data para Políticas Públicas, que se hace en Santiago en su cuarta versión este año y en Viña en su primera versión desde el próximo año. Ahora me voy a cambiar a inglés. So I'm switching over to English and to say welcome to Erin Dalton and to Amy Malone. So thank you so much for being here today. This is a long-awaited event that we were going to do earlier this year. And when Erin was supposed to visit Chile, actually, for an event of the judiciary power. And well, thanks to COVID, of course, that didn't happen, but we are so grateful and so thankful, Erin, for you to be here and also to Amy to join you. So just very brief introductions. Erin is the Deputy Director of the Office of the Data Research and Evaluation Department of the Human Services Department within Allegheny County, Pennsylvania. So Allegheny County is the county where Pittsburgh is located. And Amy Malone is, not Malone, sorry, Amy Malone is the Assistant Deputy Director of the Allegheny County Department of Human Services in the Office of Community Services. And so while Erin oversees more the data, the research and the evaluation, Amy is overseeing the family and the community supports portfolio that includes 28 family centers, home visiting programs, early childhood learning and childcare subsidy, and other programs. So we are so happy to have them both here. Allegheny County is one of the governments in the world that has been using predictive risk modeling in a very innovative and responsible and ethical way. And actually, it's one of the cases I teach in my classes when I teach data ethics as a benchmark and a gold standard on how to do things. So we're so welcome, so honored to have you here. And I'll pass it on to Erin. Thanks.
Great, thank you, Maria. And thanks, Amy, for joining. I wish we were in Chile giving this in person. Actually, the last two times I've tried to come to Chile, that hasn't happened. The conference that was previously scheduled for March was scheduled previous to that for November. And they had to delay that, I think, because of the protests there, and then COVID for the most recent. So, but I have been to Chile. I don't remember when that was, but I had a great trip and got to spend time with the research team, but also some of the folks in the federal government planning your initiative. So very much want to get back. So I'm gonna talk for a while and we'll have time for questions and answers. Amy's gonna help talk about the program parts of Hello Baby. I speak fairly quickly and I have a bunch to cover. We haven't, an interesting thing is because of COVID, we've been working, Amy and I both, and lots of people here and maybe there as well, pretty much 24/7. When we're working on COVID response. So we haven't talked about this kind of thing in a long time. So it's kind of a nice diversion from COVID, and maybe we'll get back to real work now. So I'll jump in. Feel free to ask questions if I'm not clear. There we go, sorry. But I'll try and be as clear as possible. So as Maria said, we're in the city of Pittsburgh, the county of Allegheny, in the state of Pennsylvania. We're small relative to Santiago, for example. We're about 1.2 million. We're a local government. We're not like, the folks that a lot of the folks that I spoke with when I was in Chile we're part of the federal government. You guys have really good integrated data too, but for the U.S. we have good data. So so that's part of what I'll be talking about. Just one quick housekeeping. I keep admitting people into the meeting. Do I need to? No, no. Okay. All right.
Erin, do not worry about that. That
okay,
is
I'll
done
stop
by,
admitting people
yes.
into the meeting. Okay. All right. I'll just keep, but I didn't know if anyone else was, so
Yes,
didn't
we do.
want.
We
Okay.
have people doing that. Don't worry.
All right, awesome. I will stop admitting people into the meeting. But some of our issues with predictive risk modeling, you know, there's real national, local hope for what predictive risk modeling can do. There was actually just a big Netflix show that included some of the predictive risk modeling. It was a horrible child welfare case in California, but there's some hope about how predictive risk modeling can help, but there's also lots of concerns, and a lot of those concerns in the US get caught up rightly in issues of how the government has used data in the past, particularly against people of color. So issues of race and discrimination and equity are really caught up in the discussions about algorithms in the US. So I can't pretend to understand your local or national dynamics, but when we're talking about issues, those things come up a lot. And so you'll hear some focus from me about that. And if that feels strange or you know, not on point for you, feel free to move me on. I'm trying to advance the slides and it's not quite going. All right, well that worked. Okay, we'll keep going. Hopefully they'll continue to advance. So these are the integrated data systems we have. So lots of integrated data around child and education services, around basic needs, physical and behavioral health, criminal and juvenile justice, vital records. That all drives our data sharing and data use. I'm going to talk about a couple of different uses of data, including at the person level to coordinate care. This sort of worker decision making is a key piece of where the predictive risk modeling goes, but certainly we use it for management decision making, for research, and for community problem solving as well. I thought I would just give a quick COVID example of how data can be used, because we use this integrated data all the time. So I don't know how COVID data is captured in Chile, obviously, but here there's a statewide data set. And the test data, for example, doesn't have people attached to it. They see it kind of as a specimen, as a lab test to be run. And so there isn't good race and ethnicity data in the COVID data, particularly around testing. Once we get to positive cases and hospitalizations, it gets better. But in the case of the testing, we don't have much. We can also use that data to look at comorbidity. So we can look at people who have positive cases and whether they have other physical health conditions and so on. But I'll just show you the race information. So we're able to take the COVID data, match it with the data warehouse that we already have established, and improve races. So we're able to add race values and ethnicity values, and really improve the data quality. So for example, these are COVID testing data. NEDS is the data system that we store COVID data in. So this is NEDS data only. This is NEDS data plus the data warehouse. You still have 5,500 missing race values when we do the data warehouse match, but you have 11,000 when you don't have that data. So just being able to add that much additional race data means you can talk about people and who's getting tested, because as I mentioned, people in this country, they really think that people of color are not being tested when we can show that that they are. And for us, without bringing in the ethnicity data from the data warehouse, there's literally nothing that can be said about who Hispanic, non-Hispanic, and who's getting tested. So that's just one way that we're able to use these data warehouse to help support COVID-19. Lots of other ways as well, and happy to talk about that. Just going to show you the person level view, just so you can get a sense of what data is in the system and how we use it to integrate care. These data have been available for a long time inside the agency. All of that integrated data comes down to the person level. And we, as I think I've spoken in Chile about this before, but we really want these data to be used for clients themselves so that they can manage their own care, much the way, at least we in this country and probably there as well, you guys can access your own health record and look at when your doctor's appointments are, and you can look at your previous health history. So we, for example, have views like this. This is a timeline view at the person level of in client view. And so if you were, if you had a new intake with somebody, you could see that there were 4 births of children. These blue dots here are births of children, or 5 dots actually. This is child welfare involvement, and you can see child welfare involvement started around 2015. Lots of access of community services here over the years, and you can get more information on that if you click on this little caret here. But history of drug and alcohol, mental health services, at least 1 jail stay, and income supports. And so this allows us to work with our clients more directly to help make child welfare decisions and so on. And there's just some more information about the type of information that's in client view. So you can get down to the kind of the service level as well. Also just wanted to touch on our website and what's available there. So you can go up to our website right now. You can find lots of information on the Allegheny Family Screening Tool, for example, which I'll talk about, some information about Hello Baby, but lots of data that the public can then use to help understand, advocate for change within government, and so on. There's also tools that they can use. I'll just walk you through quick screenshot, set of screenshots before we get into the predictive risk modeling. This particular query would allow somebody to take a look at over a calendar year of people who were booked in the Allegheny County Jail, how many of them had previous mental health services. And so you can see those results. You can see the overlap. So these are the big mental health services, small jail stays, and the overlap there. So it's close to 70% who have had mental health services who have been participating in the jail. And if you're Amy or I and you work on the inside, you can also download those statistics as well, and look at them by geography and a self-described geography, so that if you're interested in this and this, or if you want it at the census tract or the neighborhood or the political district, you can look at it that way. So just wanted to give you some sense of the other ways we're using data before we jump into predictive risk modeling. We'll talk about 3 approaches. So improving child protection is the one that has gotten the most attention. There was the New York Times Magazine article and that Netflix documentary that focused on a child abuse case. And so that's relatively well known. Hello Baby is our attempt to prevent child abuse and neglect. And then we're also using analytics to help improve our response to homelessness, make different decisions perhaps at the time of request for homelessness, which feels really important now as the economic conditions in the US are so challenging. So, again, and I appreciate Maria mentioning this, like the ethical sort of use of algorithms. The world is changing, everywhere about how people feel about these things. So you have to keep on this sort of thing and continue to be in touch with the community about what matters to them. So these things will shift, but we've tried to have a bunch of process non-negotiables. So, working with researchers competitively, building the models in the public domain, meaning we own them, they're not black box to us. There's 256 pages of documentation on the AFST, having independent ethical review and separate model fairness and discrimination review. Lots of community engagement. We can talk about this at length if folks are interested, and transparency about the work that we're doing. So quickly about the AFST, I know some folks here are familiar and were most interested perhaps in the evaluation. I'll focus on that a little bit, but for context, in the US, a report of abuse or neglect is made every 10 seconds, although that's down a lot right now. There's far fewer calls for abuse and neglect, but a full third, more than a third of US children will experience a child abuse investigation at some point of their lives. I don't recall what happens in Chile, but we only go out on about half of all of the calls. We do not go out on every single one. And so how do you choose which one, right? Of these calls you go out on. So this is just the point that really the predictive risk model is only being used to make a decision about whether we go out for investigation or not. These cases do not all end up in removal. Very, very few do. Less than 3% of all calls end up in removal, and there's usually services. So it's very rare that we just remove kids. So this decision is really about do we go out or not go out for an investigation. So the research team, and these are partners of Maria's as well, so Rima Vaithanathan and her partners built a model based on that administrative data that we already have. And they built a score for us from 1 to 20, where a 1 is the bottom 5% of risk, and the 20 is the top 5% of risk. And this is risk of a safety issue so significant that the child had to be removed within 2 years, right? So this is predicting a removal, but validating on other information. So if we look at those ones, right, those bottom 5% of risk, 1 in 100 of those kids end up having a home removal within 2 years. So very few of them had safety issues so significant that we had to remove. Where when we look at those 20s, those top 5% of risk, over half of them experienced a home removal within 2 years, right? And so we thought this could be clearly useful information to add to our current practice, because what we found prior to implementing the screening tool, those 20s, those top 5% of risk, we were screening out over a quarter of them, right? So those are cases we weren't even going out on, half of which had experienced, will end up experiencing a home removal, and nearly half of the lowest risk cases we were screening in, which is not a good use of our resources, our investigative resources, and maybe unfairly sort of exposing people to a child welfare investigation that really don't need that kind of oversight. So we implemented in 2016, and I'll just spend a little bit of time on the evaluation. I'll say implementation is hard, and we can talk about that at length as well, but 2 slides about the evaluation. So this is a quote from the report. Implementation of the AFST saw no adverse consequences and increased the accurate identification of children who needed further intervention services without increasing the workload on investigators. And then they also found some other important findings. So, similar, increased identification who needed further intervention, led to reductions in disparities in case open rates between Black and white children, did not lead to increases in the number of kids screened in for investigation. And then the more negative finding, or the non-finding essentially, was that we expected there to be greater consistency amongst our callers, and we didn't find that. So essentially no harmful effects, good effects in terms of screening in the right cases, if you will, and screening out the right cases, and a reduction in disparity between Black and white children at case open, which is really important to people, because there's a concern that these kind of tools will lead to more disparity in decision making and bias, because of course there is bias in these data, but there's also bias in current decision making. So implementation, as I said, is hard. We have, this tool has to be used, so it's used every single day every single time a decision is made. It's part of the workflow. It's not a choice, but we're not replacing clinical judgment. Our workers still get to make those decisions, and over time, concurrence with the score fluctuates. I'll show you the important thing really is that you have data that you can use. So this is super busy, and I don't expect you to fully follow this, but this red line are the high-risk cases, the high-risk protocol cases. And I'm blocked a little bit, you guys might be too, by pictures of us, but what you see, and it really doesn't have much to do with COVID, it started prior to COVID. We saw a change in supervisor, one of the key supervisors at call screening, who kind of reverted back to typical decision making, and they started screening out the high-risk cases again. And so it's a constant sort of discussion and training about what's important in decision making. And so these are the high-risk protocol cases and their screening rates over time. We sometimes are getting in the 80s, and then which I can't see the exact numbers, but it dipped for a couple of months recently, and we've kind of addressed. So the thing to say is that once you've implemented, you are not done. These things break. Practice needs consistent discussion and review, and you have to keep evaluating. I'm going to go really quickly through homeless so we can spend some time on Hello Baby, but it's not that dissimilar to the Allegheny family screening tool in terms of approach. So, you know, the sort of upshot of this is like, you know, if I told you that over 40% of our permanent supportive housing, these are our most expensive beds, we're going to people that were relatively low risk, you know, what would you do if we could use data to make a better decision there and make sure that those beds were going to higher risk people, should we try, right? And so that was sort of the use case with improving response to homelessness. The difference between the AFST and child welfare and homelessness is that child welfare in Allegheny County was not using like a pen and paper type assessment to make their child welfare investigative decision, where in homelessness we were. So you had something you could directly compare it to. Everything in child welfare was clinical judgment, and they had an approach, but they didn't have kind of a pen and paper assessment where we had that in homelessness. I'll skip that, but similar thing, we used the data we already have. Rima and team helped build a model that used all of these data and predicted essentially harm if left unhoused. So the likelihood within a year of having 4 or more emergency department visits, having a mental health inpatient stay, or a jail booking. And we played with lots of outcomes. And here we're validating on death. And so so the pen and paper kind of assessment tool we were using is called the VI SPDAT. And it's here, and a lot of places around the country and in Canada are using this. And then this is the predictive risk model. So the scales are a little bit different. The tool that Rima and team built us is from 1 to 10. I am hoping you can folks see over there?
Yes.
Okay, that's good. I'm the only one who can't, so that's good. That's fine, or I don't know, the way I have my screen, I can't, which is fine. So what you see, the difference here, and these lines are, for example, the orange lines are mental health, the likelihood of a mental health inpatient stay within 12 months, or 6 months is the lighter. So they go together. The jail bookings are blue. Initially, we were predicting substance use as well, which we subsequently dropped. But what you see with the VI SPDAT, and these are these are the scores from 4 to 13 on their side, is that it's relatively flat, right? So 13s aren't that much more likely to have these outcomes than 8s or 9s, than 4s or 5s. It's essentially not very reliable from a predictive perspective, where you can see a big difference between the 10s and say the 5s or the 1s or the 6s on the predictive risk model. So it predicts these kinds of harms if left unhoused better than the VI SPDAT. And then what we looked at going backwards was permanent supportive housing. When we're giving folks these beds, when we're giving low risk folks, we found that we were using the VI SPDAT because it's not that good at predicting these kinds of harms. We end up giving 43% of our permanent supporting housing beds to the lowest risk folks, right? So folks that if we had had the predictive risk model would have had a score of 1, 2, 3, 4, 5, you know, not all of the 10s, for example. And this isn't such a surprise to me, but could be a surprise to folks on the phone that when you give people things like permanent supportive housing, you see greater effect on those outcomes if they are high risk, right? So the blue here are high risk groups that were given permanent supportive housing, and the gray are the low risk groups. So those 1, 2, 3, 4s and 5s were are the low risk group. It's not that permanent supportive housing does housing. The thing that you just don't see difference because they weren't that likely to have these outcomes in the first place. They weren't all that likely to have 4 more ER visits. They weren't that likely to have a jail booking. And so you essentially see no effect with them, where you see effect of something like permanent supportive housing with those high risk groups that were much more likely to have the outcome. I hope that makes some sense. So where we are with the homelessness model was we were supposed to implement in March. We didn't implement in March, but we're gearing up to implement this summer. So we needed to give folks, I think, we just had to prepare for COVID. We had to, make changes. So now we're finishing up documentation and going to train people to implement the tool this summer. So we're excited about that, and lots of similar sort of engagement with the community, national experts, and so on. We'll be releasing all of that documentation. All right, so hopefully I'm doing okay on time. Hello, baby. Amy and I are gonna go back and forth a little bit about this. This is the opportunity to prevent abuse and neglect. So even if our call screening hotline, like the Allegheny Family Screening Tool, was perfect in making decisions, over half of the cases where a child died or nearly died as a result of abuse and neglect, there would not have been a referral. So we would have had no opportunity to try and help that family. So we could be making perfect decisions at hotline and still miss over half of the cases because they never come to us prior to that critical injury of a child. I know this has got to be true, and I know it's true in Chile too, that these injuries happen amongst young kids, very young children, who didn't come to your attention. It doesn't mean there was never any child welfare history, but at least in the US, we don't intervene unless we get a call. So there might have been a call on a 5-year-old, 2 years ago, but then they have a baby, there's no call, and then the first time we hear of this kid, there's been a serious abuse or injury or death. So this is the opportunity to go upstream, work with families from the time of birth, and see if we can't really support people differently to prevent serious abuse and neglect. So, why Hello Baby? I think like we've all internationally, nationally, locally invested in these prevention programs for a really long time. People care their whole careers trying to bend the curve of infant mortality and ACEs and significant abuse and neglect. And we haven't quite done that. And we believe we can by thinking about these 3 things. So much attention gets paid to what you give. How do you engage with people? What do you give them? What's the intervention? All of that is where people's whole careers have been spent. Whether it's home visiting or this thing or that thing, what do you give people? Relatively little attention has been paid, maybe in my view, to who you give it to. So making sure you're giving it to the families who most could use the services. And then I'm not an expert in this, but like this evaluation thing, how you evaluate, making sure you're really understanding the long-term impacts of these programs, I think is something else we really need to look at. So I'm going to turn it over to Amy to talk about the what, and then I'll come back and talk about the who we're going to give it to, and then we can have some question and answer. Amy?
Great, thanks, Erin. So, I think Erin framed it up well. I think when we think about Hello Baby, what's really exciting about it is that it really is a comprehensive tiered approach. So there is this universal layer. I think we are obviously thinking about identifying families with higher levels of need and offering them more services. I think a really important component about this, though, that we can sometimes talk less about is the acknowledgement that parenting is hard for everyone and everyone needs support. And so this undergirding layer of universal support and acknowledgement that we think everyone can benefit from that. So in part to destigmatize so that when we're reaching out to families who are at higher levels of risk, and in part because any of us with kids knows it's hard. Then there is this additional layer of additional supports for families that have higher levels of risk. All services are voluntary, so that's a really important piece of this puzzle. If a family doesn't want to engage, they never have to. And again, Erin shared the goals. So now I can give you a little bit more detail. So this is the world we imagine, right? It's very similar to very many diagrams that we've thought about before, this graduated approach where there's universal supports for everyone. I think what we think when Erin starts to talk about who we give it to, a big piece of this is being able to identify families who we think could benefit from additional layers of support early on and be able to dedicate more of our resources to doing that. So that's how the pieces can fit together in this model. Erin, if you go to the next slide. So in terms of what the program really is, so this universal layer that undergirds this program. The idea is that in all of our birthing centers, so in our hospitals, every family in Allegheny County will learn about Hello Baby. So we're working through nurses and social workers in the hospital. They'll share information. You know, you're really lucky that you live in Allegheny County. We have a network of supports available for you. Give them some materials to take home. We're developing a comprehensive website, so just navigating resources can be hard for families. Also having a phone line that has a baby specialist so that you can call and get connected to the resources that you need to. And then there are a lot of universally available services. So an example locally, we have a texting service where you can get real-time help, and they will also send along parenting tips. So promoting those sorts of resources for all families. And then we're really lucky that we have a network of family centers across our county. And those are open and available for all families. There are not eligibility requirements. So that's sort of the universal layer. Then the family center layer, again, we don't have eligibility criteria. We feel like that is really important. They are designed to be, you know, geographically in communities that have higher levels of need. So there's obviously some selection in where we place those centers in our communities. They are meant to be hubs that can connect families to all sorts of things. So I'd say, you know, their specialty and sweet spot is around parenting, home. They all offer home visiting, but they really are meant to be able to connect families to all sorts of basic needs. So whether it's food, needing support with diapers, connecting to employment opportunities, they're really meant to be hubs. What's different and special, I think, about Hello Baby is that we're planning on identifying families that we think could most benefit from support, sending those names to each of the family centers, and then have someone from the family center, so that's someone from their community who, you know, can connect with them to go reach out and deliver a diaper basket and say, you know, congratulations on the birth of your baby. I'm not sure if you knew, but just less than a mile away, you know, there's a family center in your community, and really do that differentiated outreach for families that we think are at higher levels of risk or could potentially benefit from these services more. And then Erin, if you want to go to the last slide. And then I think probably the most innovative programmatic piece of Hello Baby is the priority service. So this is for the sort of most vulnerable families. So, you know, we talked about having a baby is hard for everyone. For some, it's much, much harder. So we're talking about top 5%. And I think that using data in this way allows us to be able to sort of restrict the how many we can offer this service to, and then offer something really, really robust. And so we really scoured the research to look for the best, you know, evidence-based model to present to families like this. And what we really found was, we think that a lot of those evidence-based models, while good for lots of families, really are challenging for families with the highest and most complex needs. So they may be multi-systems involved. A lot of them sort of assume some specific, like parenting is the issue, or X is the issue. And we really wanted to start with the individual needs of every family. So I think what we've developed is, you know, taking the best evidence-based practices from those models, but developing our sort of own thing. So we're planning on providing individualized care coordination. So each family, if they choose to engage, will have a peer, so someone they can sort of relate to, maybe a, you know, mom with some older kids, and a social worker who can really help navigate complex systems that a lot of these families are navigating. That duo will have very low caseloads. So they can spend a lot of time with every family. And we're sort of thinking of it as a, here it says, do whatever it takes philosophy. So, you know, that may mean running an errand at this moment that the peer is doing, or, you know, being on the phone for 3 hours to navigate some very complex, you know, drug and alcohol treatment, trying to get into a program for a mom. You know, it is really whatever it takes. It's based on an authentic healing relationship. So we're partnering with an organization called the Camden Coalition in Camden, New Jersey. They really started in the healthcare sector in reaching out to individuals who are frequent ER users, so users of the emergency rooms. And now they've expanded to partner with organizations around the country for a variety of these sorts of services for individuals with high needs. So we've been partnering with them, and that's been great. And then we're really hoping that we'll connect to the best supports available. So really making sure that as much as we can, we are the Department of Human Services, so a lot of this falls under our umbrella, but cutting out as much of the red tape to make sure if a family says tomorrow, I'm ready to, go to X treatment, or I need this mental health service, that we don't end up with, the month waiting time to be able to make that happen. So that's a brief summary of Hello Baby priority. And I think, Erin, maybe there's just one more slide to sort of just show how this comes together. So again, if you think about the first slide that we looked at with this tiered approach, this is a lot of our programs layered onto that sort of pyramid. And so there's, the universal up to the most prioritized service, all centered around making sure that families are supported in the ways that best meet their needs.
Yep, great. Thank you so much, Amy. And so then the question is who, how do we decide who gets those highest intensity services? And I think we don't have all the answers to this, for one thing. And part of what Amy and I and Rima and folks agree with is at least we have the data to start testing well, right? So what Amy just described with our most intense approach, maybe that doesn't work with the highest risk families. Maybe we need something entirely different for them that hasn't been developed yet. Maybe that works for families that are more moderate risk, but at least we can specify who's actually getting the intervention now, because we're using predictive risk modeling to specify that. So when we think about this initiative, we're trying to, as we say, like bend the curve at a population level, not just have something that works for those families who receive it, but something that actually reduces serious abuse and neglect, potentially reduces infant mortality as well. So how do we have the maximum impact but not serve the entire population? And so this is where we sort of get in this discussion about how you prioritize and whether you use predictive risk modeling or something else. What people have typically used is either let's give it to everybody. And when we say everybody, like nobody actually tries to give it to everyone, but they say it's first come, first serve. Whoever wants it, they can come and get it. They'll tell us if they have needs. This threshold criteria gets used a lot, at least in the States. For example, something like nurse-family partnership, this is for Medicaid births, Medicaid first-time moms. So Medicaid is a criteria that is basically talking about income. And then something like predictive risk modeling, which is potentially much more precise. So, we look at something like ACEs, the Adverse Childhood Experiences Survey, and we can use our administrative data to look to essentially predict these ACEs. While we can't predict, we could, but like predict exactly physical abuse, we can use as a proxy child welfare indicators and so on to kind of look at these adverse experiences using the administrative data. So looking back at those kind of three ways of prioritizing, all births, we could try to reach out to 13,000 babies a year. We could use Medicaid, for example, as a proxy for need and reach out to about 3,800 babies a year. And when you think about Santiago or something like that, you have to think about your own birth rate, how many babies are born. So it's going to be more than 30, it's going to be at least five times that. So thinking about reaching out to families, or we could use this predictive risk model. So when we look at folks who have three, or this is going to be super hard for me to do without seeing this. I wonder if I can move it. Oh,
on the top
yeah,
right part of your screen?
Yeah, I can move it, thank goodness, because it was going to be really hard. This is the risk score from 1 to 20, and this is the proportion of children who experience 3 or more of those adversities, as we showed you, the proxies for those adversities over the first 3 years of life. If we reach out to all 13,000 babies, and the different bars here are Black children and non-Black children, because race is so important to look at, and at least in our context in Allegheny County. So you could reach out to all 13,000 babies, and if every single one of them engaged with you, 2.4% of those babies would end up having those 3 or more adversities in the first 3 years of their lives, and 0.5% of the white kids, right? So in terms of bang for your buck, spending that kind of resources to reach those kids. You're not getting all that much. Medicaid as the proxy, which is what everybody basically uses, doesn't do much better. It's not that good of a proxy for these adversities, where something like predictive risk model, what we're talking about is trying as hard as we can to engage all of those 20s, 11% of those white kids, 10.2% of those Black kids end up having those 3 or more adversities, making the argument that if we reach out to 600 babies and really try to give them what they need, we'll have more impact at the population level. It's the same thing. This is the same thing sort of over and over. This is the proportion of kids with safety issues so significant that we have to remove the child from the home by age 3. So if we reached out to the whole population, only 4% of Black kids and 1% of white kids would end up having that adverse experience. Medicaid does a little better than, so reaching out to 7,800 kids, but when you look at the sort of bang for your buck you can have for when you reach out to those 20s, it's just so much better. I'll just do one more, and that's mom going to jail. Similarly, you can just have much more of an impact. And people in the U.S. are often surprised that it's the white families that are more likely to have these outcomes than the kids of color. So it's not that we're only giving this intervention, the supportive voluntary intervention to families of color. There are white kids too who are very high risk for these kinds of adverse outcomes. So that's essentially what we will do. Like, as we've sort of said, all of this is kind of a big test, but at least we have the data. So we would try and reach out to the 20s with that intensive supports that Amy mentioned. The more moderate risk families would get the enhanced outreach from the family support centers, and then everybody's eligible for a bunch of universal supports. And so we're really, I'm struggling, we're struggling, everybody's struggling with evaluation, and we need a more expensive evaluation than we have funding for. So we're a little bit back in the drawing board trying to make sure that we have the right amount of funding to do really careful process evaluation and understand what's working in engagement, because as you guys know, engaging families is so difficult, and really be testing things to improve engagement. And then making sure we really have a partner who's willing to look at all of the various types of outcomes, look at them in a long-term way, and partner with us so that we can all, on behalf of the country, international study, really learn as much as we can about what works for families across these various risk thresholds. So I'm going to stop there and open it up for question and answer. Now I want to put these people back where I can see them. Okay, good. I can put them back where I can see them. So Maria,
yeah,
whatever questions. Yep.
Thank you, Erin, so much. That was really interesting. So todo este el momento de preguntas. Si quieren pueden por el chat hacer preguntas en español o inglés, da lo mismo, y yo le voy a traducir a Erin para que por el chat ustedes puedan hacer preguntas. So while we wait for people to ask questions through the chat, I did have a question. So how is the implementation on Hello Baby going? How far along is it?
Yeah, good question. Amy, do you want to take that and talk about what we've done given COVID and where we're going?
Sure. Sorry, I was trapped on mute. So our original plan was to launch in May, then COVID happened, and so we had to pause. So we selected the organization who will do the Hello Baby Priority Service. They started hiring. They've been trained by the Camden Coalition, and then COVID happened, and so we did not want them to sit idle. So we actually started receiving referrals from our biggest birthing center, McGee Hospital locally. They've received over, I think, something like 75 referrals in just the last 3 weeks. And so right now, we are not using the predictive analytics data to identify who they're reaching out to, but we're using hospital staff who, for the most part, moms who maybe had no one they were really in contact with while they were there, worried about in this very isolated time, not having someone to support to go get groceries or anything else. So it's a very modified, they're bringing a diaper basket to those families and asking if they need support and making connections for food and other basic goods. And the hope is, I mean, one big outstanding question for us is when home visiting will return, both on the home visitor, the provider side of when people feel comfortable going back into houses, and when families feel comfortable accepting family or accepting providers into their house. So yeah, we're trying to figure out when we can fully launch given the realities of COVID.
That's definitely a big challenge.
Mm-hmm.
And Erin, oh, here we have a question. So how do you manage expectations of workers and managers about the results of PRM compared to traditional methods?
Let's see. I'm not sure I know how to answer that. I guess we've done a lot of engagement with the workforce, but I think if I think about child welfare and homelessness, the thing that we've done differently between child welfare and homelessness is we've engaged the workforce a lot more with homelessness. So they're very, very engaged in this model development. So they pull lists. We pull lists, for example, of people that had a low VI SPDAT score and a high predictive risk model score, and we case reviewed all of those, and there are really good reasons. It's really fun to do that because there are really good reasons why that happens, and cases that are the other way. They haven't had outcomes to look at before. For example, for homelessness in this way, they think, of course, they're serving the best clients, like the clients that most need help, but we didn't have a structure by which we said, no, we're going to look at harms if left unhoused, and look at how we're doing in essentially reducing the likelihood of these harms, like 4 more ER visits and mental health inpatient stay and jail booking. And so I think that one's going to be interesting because they're just they don't know what happened. Like, they know there's people going to housing, they assume all is good, and they don't really know what's happening with the people who get left unhoused either. They just keep trying to get them, into housing. I'm probably not answering the question very well, so maybe someone wants to take another add on to that to make sure I actually answer it. But we do a lot of work with the workforce on this.
So usually when you think about the whole process of the Allegheny family screening tool, how much did you percentage-wise, even in budget or time, do you want to dedicate to design versus to implementation and redesign and monitoring and evaluation, the whole process?
Yeah. What I would like to do, but we never actually do, is fail faster, because it's never going to be perfect. We spend a ton of time talking to all kinds of people, including the workforce, and then things happen that we didn't predict would happen anyway, and so we have to always make changes. So I always want to get to that point faster, but that never happens because people really want to understand every single piece all along the way. So what we do and what I think we should do are two different things. What we do is spend at least 3 times as long as I think we should designing, and then of course we have to continue to refine along the way regardless.
Yeah, so somebody was just asking specifically how much effort was required for the problem's conceptual and process design versus the technological part of it. So comparatively, the part of actually building the, doing the predictive risk model, analyzing the data versus the other part.
Yeah. Rima might have a different answer to this, and Maria, in your own experience, you might have a different answer. I think conceptualization is the hard part, and that once the data is provided, they can run different outcomes all day long. That's not hard. So if I said, no, Rima, I want substance use back in as an outcome for the homeless model, she'd give it to me tomorrow. So that part's not that hard. It's how do we think about what we're trying to do in homelessness, and conceptualizing that it's really these like ideas of harmed if left unhoused as an infrastructure. Similarly with child welfare, and like how we're using proxies for serious abuse and neglect, right? So structuring the model around the outcome of home removal, safety issues so significant that there's a home removal. We're also previously predicting the likelihood of re-referral to child welfare, but it just doesn't do as good of a job in identifying these really high-risk cases. So I think so much of it is understanding what the decisions workers think they're making and how they're making them, and designing proxies, because none of it's perfect. Even like when we talk about those ACEs, we don't have perfect views of adverse child experiences. We have sort of proxies for that, and Rima and Emily Putnam-Hornstein both spent a lot of time helping us conceptualize all of those things, and I think that's a big part of the intellectual sort of property that they've helped us with on this. And the technical stuff is important too, but it gets played out from this bigger sort of set of ideas and philosophies.
Thank you. And there's a question around size in terms of how would you think that the number of people in a city, like considering, for example, Santiago, that it's much bigger than Allegheny, would influence the way the model is applied?
Yeah, I mean, and Maria, feel free to. Like, I think it just gets easier the bigger you get. California and New Zealand, and Rima's doing work in Colorado too. Like, they don't need to use, for example, the integrated data to get the same results that we're getting on child welfare. They just use the child welfare data alone, and they can create a very accurate model. We're smaller. We need to use all of the data that we have, and so these power goes up with the size. I'm sure there's some complications to that too, like some complexities there that data scientists would suggest you want to be careful with. But I think the more data you have, and you guys, my understanding is, have pretty good federal integrated data, that you have more than enough data to run these kinds of models. The question is really how you want to use them to support people.
Great. It seems I've just asked if somebody wants to do a last question, but it seems that we're okay. And I don't know if Amy, you would want to do a last comment, some closing words.
I don't think so. I mean, thanks for the opportunity to share. I hope that we can come back, in 6 months or a year once we've actually launched, and we can tell you how it's going. Because I think from my side, on the program side, we're just really anxious to, start to be reaching out to families and see how this goes.
Yeah, and I do have one last question. So is the homelessness, are you planning an evaluation of the homelessness model? Maybe I didn't catch that.
We are, yeah. We have not, we did release a solicitation around Hello Baby. We're going back and forth on that a little bit. But we have not released an evaluation yet for the homeless model, but we will evaluate it. Yes, for sure.
Great.
Yeah.
Well, thank you so much. If anybody wants to learn more about these models, you can go onto the website. They're very well documented if you're from universities or students. It's a really good place to go and learn or to use as cases, because there's a lot of information, technical information, but also information like frequently asked questions in terms of also the communication to the users, to the community. So I invite you to go visit that website. Thank you so much, Erin.
Yeah,
thank you, Amy.
Thank you. Thanks for having us.
Muchas gracias a todos por venir, y los invitamos a la próxima charla. Es el próximo martes. Es sobre introducción a ciencia de datos para políticas públicas, así que si pueden avisarle a sus conocidos, ya la estamos difundiendo a través de nuestro Twitter, y les agradecemos a todos por venir de parte del GobLab y del Centro de Economía y Política Regional de la Universidad Adolfo Ibáñez. Que les vaya bien. Chao.
Chao.
Chao. Bye.